All right, it looks like we have a good enough crew here. Again, my name is Dr. Taylor Gannell. I'm one of the attendings here at MUSC. Welcome again to the Southeast Body Club. We appreciate everyone being here and are looking forward to some good teaching. We're going to start with one of our fellows here from MUSC, Dr. Zachary Brodell, and we'll go from there.
All right. Hello, everyone. My name is Zach Brodell, one of the body fellows here at MUSC, and I have an interesting case to show you guys. So, relevant history with this patient, she's a 52-year-old female, end-stage renal disease on hemodialysis. She presented initially to the emergency department for ongoing vomiting and change of bowel habits. As part of that workup, she had an outpatient colonoscopy, which was reportedly normal. So on the CT that ordered from the ER, we have this large solid cystic mass emanating from the pelvis. You can see that there's these like stipple calcifications kind of throughout it. We brought up the concern for a GYN malignancy of probably GYN origin and likely from the ovary. Got a MRI the later same day. Unfortunately, they weren't able to tolerate the being in the magnet for very long, so all we have are the non-con images. But we have this very T2 hyperintense heterogeneous mass that, if you scroll through the images, it was coming from the right ovary. And during that hospital stay, they actually had this resected, and it came back actually as a malignant transformation of a mature teratoma, particularly of the endodermal component. So, kind of just briefly, as all of us know, in terms of like the mature teratomas, it's really of greater than two or more of the germ layers. So ectoderm, mesoderm, endoderm. Um, and really, the kind of defining feature with these teratomas is the macroscopic fat. Commonly also see these teeth calcifications, but then you can also get monodermal components where you can get the stroma ovarii. Rare complication with these is in this case is malignant transformation. Occurs in about 1%, and kind of this typical core test materials. Squamous cell carcinoma is the most common cell type that transformations into, but some mucinous adenocarcinoma is a very rare subtype. So in terms of the actual malignant transformation, so what the idea of this is, it arises de novo from arising from a benign dermoid, as opposed to an immature teratoma where that does not arise from the dermoid, and that's more from embryonal cell types. Again, this is commonly squamous cell carcinoma in greater than 80% of cases, with the mucinous differentiation being much more rare. In terms of the imaging clues from that you can suggest that this might be the cause of it. I mean, in terms of the lesion itself, has some sort of fat component, so kind of describing the macroscopic fat. But in terms of the malignant transformation, particularly if you have new heterogeneous enhancing solid components, and then depending on the grade and the differentiation of the lesion, can show transmural or invasion through the capsule. So if we go back actually to the initial CT, we can actually see, in addition to the solid cystic mass that's predominantly involving it, that there actually is an area of macroscopic fat over in the left side of the lesion. Um, and that is actually what they use to kind of comment on the pathology, that given the fact that the colonoscopy was negative and there was no other primary, and upper endoscopy was also negative as part of their workup for this vomiting and change of bowel habits, that this is likely a teratoma that had the mucinous degeneration from the endodermal component. In terms of the mucinous transformation, I mean, it's very similar to what we see mucinous tumors elsewhere. I mean, very T2 hyperintense mucinous component. The lesion itself, it can mimic a epithelial ovarian neoplasm that I'm sure we've all seen. And in terms of the other disease involvement, it can also, again, depending on the degree of differentiation and the grade of the lesion, can present with peritoneal carcinomatosis if there's invasion through the capsule. And again, what I want to show that CT, the fat itself indicates that this could be a teratoma, and then again, with all this taken into context, this mucinous or the malignant degeneration of it. So, I mean, in terms of just really the take-home points for this case, I mean, so teratoma, we don't want to just think that we see fat and this is a benign lesion, but really have an understanding that the teratoma can have these complications, and one of which is being this malignant transformation. The thing you were really looking for is that solid enhancing component is a big red flag in terms of suggesting that this is the complication is occurring. And again, the most common true transformation that we get with this is squamous cell, but it can really be any of the dermal layers or germ cell layers that can have malignant degeneration. And then this particular case was of the endodermal component to the mucinous adenocarcinoma. So that was my case, my references, and thank you.
Thanks so much, Zach. We've been talking a lot about ORADs here at MUSC, and what Zach kind of said. If you go down the path of doing the calculator for ORADs and you get to the fat component, one of the next questions it asks is if there's a large component of solid enhancing tissue, which will upgrade it on the ORADs grading system. So something to definitely think about. All right, next we have another MUSC fellow, Seth Russell.
All right, so let me get this up.
And please, any other attendings that are on, feel free to chime in if you have any teaching points or anything else to add.
All right, so my case it's going to be, well, Southeastern Body Club. Let me click. About granulosa cell tumors and ovarian sex cord stromal tumor comparisons. So case background: 57-year-old woman, came in with postmenopausal bleeding. Her only symptom at the time. Did an ultrasound, found this mass in her right ovary, and there's no internal vascularity within this one specifically, but you can see a few cystic spaces within it. Solid kind of hypoechoic mass. Go on, got the MRI. So you can see this right adnexal lesion. This is the earlier phase here. Later phase, you can see kind of progressive enhancement. You can also see you got endometrial thickening here, and some of the intrinsic signal, you got kind of a mix like T2, like a more fibrous kind of component, and then like an intermediate kind of more evil gray looking signal there. So go ahead and, I mean, this ended up being a path-proven sex cord stromal tumor, but kind of a little bit more about where these things fit in. It's kind of a list of your neoplasm incidence by lineage. So sex cord stromal tumors, you can see about 5 to 8% of gynecologic tumors amongst these other typical gynecologic tumors. And then when we talk about a granulosa cell tumor, it's the most common malignant ovarian sex cord stromal tumor. Between that and Sertoli Leydig, that's kind of the other main, like, I guess, more sex cord tumor, at least it's going to be malignant, typically a lower grade malignancy. There's an adult type, peak around, post-menopause around 50 to 55 years old. That's where about 95% of cases occur. And then juvenile type, which is, children, young women in their 20s, about 5% of cases occur in that population. Typically, they're going to be unilateral and confined to the ovary presentation. And they're going to be functioning, which is one of the key things with regards to all these, as I'll get into in a second. So you'll get bleeding, endometrial hyperplasia, polyps, cancer, and again, indolent biology, but they can recur over a long time frame. So this will be a little redundant here for a second, but I mean, imaging features, you can get mixed solid, it can be predominantly solid, like the case that I had was more of a solid case, with just a little bit of cystic changes in it, but you can get some that have more cystic components in them as well. And solid portions are typically vascular. Granted, the one that we had was not, at least on ultrasound, but obviously it did enhance. And then you always want to assess endometrium in these patients to get an idea for, again, like any of these masses, if they're actually hormonally active or not. So CT typically going to be used more for staging complications, anything like that. But similar, I mean, same appearance, cystic, solid, mixed. MRI, again, you get kind of more like a fibrous component with mixed appearance. You can have some cystic components. You get a little bit of typically a fibrous component, and you get some of that intermediate signal as well. And then kind of the key to all of this, it kind of actually like comes down, clinical is such a huge factor with regards to any of these tumors, which kind of run through here real quick. So this is just a quick comparison of several of the different sex cord stromal tumors. Granulosa cell tumor secretes estrogen. You get abnormal uterine bleeding, thickened endometrium. All these have overlapping imaging features, but these are low-grade malignant tumors, grow very slow. Like the case that we had actually presented it, I think it was like 7 years before, got lost to follow-up, had slightly increased in size 7 years later. We go on fibroma. So these are non-functioning, typically associated with Meeks syndrome. It's going to be a T2 dark solid mass, like all the way through. They don't typically have that intermediate T2 signal, kind of like the granulose cell or Sertoli Leydig tumors can, and those are benign. Thecoma, fibrothecoma, these secrete estrogen, which that's the overlapping kind of feature with granulose cell tumors. They're typically more on the lower, like they typically have more of a fibrous component as compared to granulose cell tumors, but those are benign as well. Sertoli Leydig cell tumor, that's the other one kind of alongside granulose cell tumor where it's low-grade malignant potential, but they look very similar. It's just the clinical presentation is kind of the main thing. So you get, like we had another case recently actually in tumor board, like clitoromegaly, viralization. So just all those classic features, which kind of really points you towards the direction of what the actual diagnosis is, since they have so many overlapping features. But they'll have same thing where they've got kind of variable like T2 low strom. You can have an intermediate signal component as well, and some cystic regions as well. There's another one called a sclerosing stromal tumor, which is a benign tumor, typically presents in a young patient, like late teens, 20s, pseudolobular peripheral symmetrical enhancement. I've got the characteristic imaging here shortly to share for that. So yeah, fibroma, fibrothecoma, I mean, you can kind of see more like a fibrous component, like a very, very fibrous component, and you get just kind of progressive enhancement, kind of the core stuff. Sclerosing stromal tumor, it's a rare benign sex cord stromal tumor. You can see it's typically second to third decade, presents with pelvic pain, very nonspecific menstrual symptoms, bleeding, just very like an array of nonspecific symptoms. It's got kind of like a pseudo like lobular architecture. You can kind of see it's got a pretty good or T2 hyperintense cellular kind of nodules within. And then you get like a peripheral kind of enhancement like this, like all around the outside of it. So that's kind of like this is the classic appearance of that type of tumor. But yeah, young patient typically. Sertoli Leydig cell tumors, again, rare viralizing ovarian tumor. The androgen excess is kind of the key, similar imaging features to the granulose cell tumor. And so that's kind of like the main comparisons and main things. So, I mean, effectively, a lot of this comes down, like they have so many overlapping features. With the fibrous tumors, you're more so going to get like fibroma or fibrothecoma. You'll have more of a fibrous component than a cystic component. Typically, they won't have the intermediate signal as often, but again, overlapping features. And the thecoma aspect is also hormonally active, secreting estrogens, and that's the overlapping feature for granulose cell tumor. So kind of the main thing, like, yeah, you can get so many overlapping imaging features on a spectrum, and then you want to use the clinical picture of kind of what's going on with the patient, the hormonally active aspect, to kind of point you in the direction as well in conjunction with those imaging features. But yeah, that's my presentation. I've got some references at the bottom.
Great. Thank you so much, Seth. Yeah, I think that's something for everyone to keep in mind when we see a postmenopausal patient with endometrial hyperplasia or just thickening of the endometrium. Make sure you're looking for these ovarian tumors that could be releasing or producing estrogen as a potential cause. Great. All right, moving along, we are going to Dr. Stephanie Schwartz with Vanderbilt University.
All right, hello. I'm just going to pull up the PowerPoint real quick. Need to. Screen. Okay. All right. Everyone can hear me and see it, right?
Stephanie, I think you're sharing the wrong window.
Okay, hang on. Share entire screen. Yeah. All right. Does that look okay?
Yes, there we go.
Thanks. All righty. So to start off, we have a 63-year-old male with diplopia, vertigo, blurry vision, and headache. So I know that sounds very neuro-like, but we'll see later why that's relevant. And then urinalysis showed some signs of UTI, but otherwise the remaining labs and vitals were within normal limits. So also a little additional background for this patient before his presentation to the ER was a week prior, he did get a scrotal ultrasound done for right scrotal swelling. So you can see that the right testicle is markedly enlarged compared to the left, definitely more vascular, and there's kind of this infiltrated hypoechoic masses all throughout, or just appearance of the parenchyma, and a large complex hydrostele. So more ultrasound images shows that the epididymis did have a similar appearance to the testicle, kind of hypoechoic throughout with increased vascularity. There's some more pictures, and then also some nodules along the tunica there. So more background, past medical history for this patient. He was diagnosed with prostate cancer in 2022. Prostatectomy was aborted due to severe desmoplastic reaction, but they did do a bilateral lymph node dissection at that time. There was one positive node with extranodal extension. He did get radiation and hormone therapy. And then follow-up post-treatment PET, PSMA PET showed some mild uptake in the prostate and seminal vesicles, but otherwise nothing too concerning. But then later that year, CT abdomen pelvis showed concern for recurrence as well as METs. So lymphadenopathy, pulmonary nodules, adrenal nodules, and he was started on immunotherapy at that time. And then also of note, his PSA was currently undetectable. So that was just a little interesting. So at this point, differential, I mean, it's a long list, but just to kind of keep it more simple and to the point, the differential would be prostate cancer recurrence with METs to the testicle, lymphoma, or just infection. He was presenting with, he had the UTI, and then he also had some neuro symptoms as well. And then typically prostate cancer, it's pretty rare for that to met to the testicles, but it can happen. So then since he did present with the neuro symptoms, he did get a CT, so you can see all these hypoattenuating lesion-like areas throughout the brain with some edema. And then MRI also showed some ring-enhancing lesions with surrounding edema kind of all throughout the brain. So then differential would be kind of similar, obviously more suspicious for METs at this point. Certain infections can look similar. And then a repeat CT. I know this is kind of small to see all the findings, but there is lymphadenopathy, left adrenal nodule, and then this right pelvic side wall lymph node and or mass kind of abutting and possibly involving the urinary bladder on the right. So this patient ended up having biopsy proven conversion or transformation of his prostate adenocarcinoma to a neuroendocrine small cell carcinoma. So that's relatively rare. And then he did get a bladder biopsy, which showed metastatic neuroendocrine small cell carcinoma. And he ended up getting his testicle removed too. So right orchiectomy pathology also showed metastasis to the testicle, epididymis, spermatic cord, and extensive lymphovascular invasion. So neuroendocrine transformation of prostate adenocarcinoma, it's also known as treatment-related neuroendocrine prostate cancer. It's rare and highly aggressive. So as I mentioned before, usually you don't see that extensive of METs with prostate cancer, including the testicles, but with this type of transformation, it's more common to get really aggressive metastasis, and it is associated with long-term androgen deprivation therapy or second-generation anti-androgen treatments, which this patient did receive as prior treatment. And it has to do with loss of androgen receptor signaling and loss of tumor suppressors. So it makes it resistant to standard hormone therapy. And then with this type, they often have stable or low PSA levels. So this patient had undetectable PSA level. And then the treatment would be prompt aggressive chemotherapy, but unfortunately, it is pretty poor prognosis, about 12 to 16 month survival with a median of 18 months survival. So this patient definitely has widespread mets, throughout brain, chest, abdomen, pelvis. So it's not looking good, but I just thought that this was kind of an interesting thing because I haven't really seen any of this specific entity. So thought I'd share it.
That's a great case. Yeah, very,
That
very
is a
interesting.
strange case. Yeah. Can you go back to the first image that you had up?
Of the scrotal
ultrasound. Yeah, I'm just trying to burn that into my mind. Wow, yeah, that's interesting.
Because of course you might think, typically more of the hypoechoic diffuse infiltrative thinking lymphoma, right, and then things, but yeah, and then also with the nodules, that was kind of different as well.
Wow, great case.
Excellent, thanks.
All right, moving on next to Dr. Teddy Tran, also from Vanderbilt.
All right, let me share my screen again. Cool, let's do this, slideshow. All right, cool. All right, hey guys, name's Teddy. All right, so my case, we have a young female patient. She's 28, G1P1. She has a lump on her vulva for the past few years, and it kind of gets worse around her period time. No history of cancer or no other relevant medical problems either. So the first thing they do is they get an ultrasound for our favorite lumps and bumps. And this is kind of what the ultrasound looks like. So you see here kind of more heterogeneous, maybe some solid components too. There's some flow in there as well. Of course, in this, our favorite thing is say, not really sure what it is, get some more imaging. So we recommended them to get an MRI for this. And so this is what the MRI shows. You see here, there's a kind of T2 heterogeneous mass. Maybe there's some T2 hypointense areas in this as well. So the first thought, we kind of need some more sequences here. So going to our pre and post contrast, fat saturated T1 weighted images here. You see some internal hyperintense foci of T1 signal here. And for enhancement, there's a little bit of enhancement, not too much. So just going off the bat of this, this has a pretty good look for a endometrial implant. And what's really interesting is kind of the actual location of where this is at. So kind of going back to it, kind of in the right inguinal region, kind of along her lateral aspect of her right mons pubis, or maybe labia majora. So this actually came out to be a canal of Nuck endometriosis. So here's a little bit of information about the canal of Nuck. If you haven't heard of it, I didn't hear about it or know about this until this case. It's a pretty rare entity, and about majority of it will happen on the right side, kind of like how it is in this case, and that's thought to be kind of how the peritoneal fluid within the abdominal cavity drains. That's why it ends up being more so on the right side, but it's not just isolated to being susceptible to endometrial implants. You can have other entities such as just a hydrocele or a hernia as well in that area. So this is kind of pretty neat, rare location for endometriosis, because I'm sure we get all sorts of imaging all the time looking for endometriosis, and kind of here's a little bit of information about that as well. So it's becoming more and more recognized, and the more interesting part is that the latest update for ACOG for their management and evaluation for this process now includes imaging as well. So it's kind of how radiology can play a more important role for allowing the obstetricians and gynecologists kind of to work up their patients for endometriosis. And as we know, there's superficial, there's the classic endometrioma, and there's the deep infiltrating endometriosis, was kind of what they will most likely or most commonly order the advanced imaging for, because just kind of no one is involved and whatnot. So after this, I have a few other cases of kind of other areas of endometriosis, but I thought there was kind of a neat location for it. So, here's your classic sonography appearance of the endometrioma. You see some low-level echoes as well. So here's a pretty big implant here. So you see our classic shading on T2 and a bright signal on T1. Here's some other ones too in the same patient. And then here's some involvement of the deep infiltrating endometriosis. So, here's some thickening here in the anterior compartment. Here's some more thickening kind of along the bowel as well, and also along the peritoneal lining here. Some bowel involvement here. Here's our little cute mushroom cap sign. I'm showing some involvement of the rectum. And then for patients who've had C-sections or anal surgical intervention as well, always keep in mind of some implants along the incision line or scar. So here's some examples of implants along the C-section line scar. And this actually just came in recently, that we always hear about the elusive catamenial endometriosis, and we actually had a case of this this past week. So, of all the negative ones we see, sometimes there will be a positive one. So this is kind of a neat one. This patient came in with right shoulder pain, and she had severe deep infiltrating endometriosis as well. So they're looking for any implants on the diaphragm, and it came out to be real. So kind of neat. And these are my sources.
Great. Thank you so much. That was an awesome case. You all will probably see the Canal of Nuck a handful of times every year. They seem to come through. And that's just a really neat case of endometriosis in there. I believe that you can have both encysted or non-communicating canals of Nuck and communicating as well. So just a great example of where it's communicating and affected by endometriosis. That's great. All right, moving on, we have Dr. Vincent Stephen from Duke.
All right, can y'all hear me? And it says my time to be prepared and loaded. All right.
You sound a little distant from the microphone, possibly.
All right, we're just gonna yell out because I don't know where the mouse, where the microphone is in this room, but presenter view. All right. So my name's Vince, one of the body fellows at Duke, and whoops, wrong way. All right, so we have my case has some themes that we've seen before, but some things different too. We have a 36-year-old woman, and she's got getting evaluated for a right adnexal mass. She previously had a left adnexal mass, a while ago. We'll talk about what that was later. All right, so starting off with the right adnexal mass, I have it circled, right? There's a mass here, and we see that it has some cystic spaces on this T2 fat sat. On our opposed phase T1 images, we see some India ink artifact, where it's dark on the fat suppressed images, so it has macroscopic fat in it, but it also has like a solid component that's enhancing here. So this is a fat containing lesion. We know it's probably a teratoma. of some sort, as we discussed before, but does have that solid enhancing component. But we also have some other findings. So this top left image is a T1 precon. You see there's an intrinsically T1 bright lesion along the right, in the right hemipelvis along the peritoneum. But similarly, there's another nodule along the peritoneum here. I'm just going to take my word this is a peritoneal nodule, not any of the bowel. This is not intrinsically T1 hyperintense, but it enhances. So it's an enhancing soft tissue nodule in the peritoneum. And then just coming down here on our T2 high-res images, we see that there is some T2 dark fibrotic thickening along the peritoneal reflection here. So, these three images are kind of supporting that this patient has, at least in the background, some infiltrating endometriosis, or some, a more fibrotic component here, and here having a more T1 intense component. But we have this other peritoneal nodule that's not definitely an endometrial implant. And I'm just using these both as representatives because there's other peritoneal and mesenteric nodules as well, some of which are T1 hypertensive, some of which are not. So this patient subsequently got a CT, and on this left image is from just about a week or so later. These are just some correlates for what we saw. We see that fat-containing mass in the right adnexa, teratoma with a cystic component as well. We see this is the intrinsically T1 hyperintense focus here, which we can see has a little bit of a cystic appearance on the CT at least, although it's more T1 hyperintense. Our endometrial implant, and this is our other peritoneal nodule. And they subsequently got follow-up 3 months later. We see not much has changed. This teratoma is in slightly different orientation, but not significantly changed. This endometrial implant, not significantly changed. And this other peritoneal nodule, although the bladder is a little bit in different positioning, is the same one, it's not changed either. So even though this implant is not following, it doesn't look like an endometrial implant necessarily, it's not really acting like a malignancy in that it's not getting bigger. And this patient has not undergone any sort of treatment in the meantime. So going back to this patient's history, they had a prior left salpingo oophorectomy, and they had an operative findings. They found an ovarian mass, and they had a bunch of whitish peritoneal implants. They sampled a bunch of things in the peritoneum, and ultimately they had an immature teratoma on the left, which was grade 1, so relatively low grade, but still immature. And then the peritoneal biopsies were all benign. However, they had some interesting findings of having both endometriosis and glial tissue, showing gliomatosis peritonei. So all these findings here, we go back, kind of are in concordance with that, meaning that we saw that there was things that look like endometrial implants and other findings of deep endometriosis, but also these other peritoneal implants that didn't seem like endometrial implants, but weren't really getting worse as far as we could see. So because of the fact that this patient's history, and we had that soft tissue component on their right ovarian mass, they did get it resected. There was another mature cystic teratoma, or it was a mature cystic teratoma, not an immature teratoma like they had on the left side. And I primarily wanted to talk about gliomatosis peritonei, because I think it's a very rare entity, but it exists. So this is like when you have mature glial tissue. When I say glial tissue, I mean like brain, like neuronal glial tissue in the peritoneum, which obviously not supposed to be there. It's almost always associated with immature teratomas in women. Rarely you can have it with mature teratomas. I think I saw one thing talking about having glial tissue in the peritoneum in the setting of a VP shunt. I don't know how. I think that was just like something I read somewhere, but I don't think I don't know how often that actually is real. Radiographically, it's not like we're like able to call this like we can call it like endometrial disease. It's really a tissue diagnosis, but it is, however, a benign explanation for something that looks very malignant. So it's important to consider these are not considered metastases. These are just benign differentiated glial tissue from the teratoma, but it's not metastatic immature teratoma in the peritoneum necessarily. So it's not treated like with chemotherapy unless you were to sample some and find that there were malignant tissue there. It would be treated very conservatively. If these things cause mass effect somehow or cause some tethering or an obstruction somehow, then you treat it like that. You wouldn't treat these in and of themselves. It's not exactly the same thing as this, but it kind of to me shares a neuron, like growing teratoma syndrome, right? Those are masses that are differentiated tissues, but they're not considered progressive disease. And so similarly, these are peritoneal masses related to the patient's primary immature teratoma, but not metastases. So that's all I have for you. Thanks for your attention.
Very cool case. I'm appreciating our kind of continuity of education here. We're doing a lot of similar things, and it's all kind of joining together to be good education. So we appreciate that. All right, next moving on to Dr. Joshua Bolter, also from Duke.
All right, I'm Josh Bolter, and keeping with our theme, I have some more GYN case for you. So I have this 28-year-old female, sorry for the wordy slide, but she's coming in with an elevated beta HCG. So for the past month, she's had this low-level elevated HCG from 10 to 55, slowly rising over the past month. She does have a history of molar and ectopic pregnancy, and 2 successful pregnancies in the interval. So they presumed she had ectopic. Ultrasound was negative, but they were treating her as presumed ectopic pregnancy with methotrexate, in which her HCG was not improving, and she had a DNC as well that was negative for trophoblastic tissue. So after the negative DNC, they did an MRI to see if there was any reason for this elevated HCG. And what you're seeing here on these axial and coronal T2 weighted images, just believe me that this is the normal uterus here, and then there's this mass here, this heterogeneous T2 mass in the uterine fundus, kind of in the corneal region. We've got some T1 weighted images here, pre-contrast fat sat. You can believe me, these aren't the greatest cropped images here, but there's some T1 intrinsic hyperintensity here in the region of that mass. And then there's a heterogeneous enhancement as well. So presumably some blood products inside of there. We recommended her to get an ultrasound because the prior couple of weeks ago was negative, just to see what this was looking like on ultrasound. This was done by OBGYN, but you can see there's this mass in the uterine fundus, reasonably isoechoic, maybe hyperechoic to the uterine myometrium. You can see there is a little bit of myometrial tissue separating the endometrium, so it's more centered, maybe at least in the myometrium, or on MR it was looking a little more corneal, but either way, it's centered in the myometrium here. So differential at this point was, at least with our MR, we were thinking, could this be an ectopic pregnancy? And then looking on the ultrasound, it looks more like a solid mass, and bringing to the question, could this be gestational trophoblastic neoplasm? Much less likely to be these other findings given the MR. So she had a resection of this mass, and it came back as a gestational trophoblastic neoplasm in a rare subtype epithelial trophoblastic tumor. So I figured I'd talk a little bit about this, just to clear up what this is. Like, gestational trophoblastic disease is a spectrum of, or a group of diseases, some of which are neoplastic, and more familiar are the molar pregnancies, which complete in partial molar, and then neoplastic version of like an invasive or metastatic molar pregnancy. But there's also choriocarcinoma and a couple other subtypes that are more rare, which we're seeing with this patient. So I guess the point of this is, maybe we weren't thinking as much along the trophoblastic disease because the HCG was so low. But I guess these more rare subtypes are more associated with low-level beta HCG, as opposed to choriocarcinoma and these molar pregnancies where we're seeing much higher elevated HCGs. So just to summarize, just keep this thought in your differential, particularly with that low HCG. That's all I got for you.
That's a great case. That's really good. So is that you said in the history this woman had prior molar pregnancies previously?
Yeah, she had one molar pregnancy and an ectopic pregnancy on separate occasions.
Wow. Okay. Well, that's a really neat case. Thank you for sharing. Um, all right, we're moving on. We're next going to be with Dr. Catherine Zhang from Emory.
Hi, can you guys hear me okay?
Yes.
Okay, awesome. All right, so here's my presentation. So background on this patient, it's a 65-year-old male who has a history of multiple sclerosis, right leg melanoma in 2023, lost to follow-up, and then right frontal meningioma. He recently moved from Texas to Georgia, and he has a recent, like within the last year, history of anemia and melanoma without any colonoscopies prior. He's a poor historian, and he's presenting with worsening falls, and due to his falls, he had a fibular fracture. So his pertinent lab findings, he has a hemoglobin of 7.2 and a white count of 9.2. And then here's his imaging. So here we can see this is the cecum over here. There's large aneurysmal dilatation of the cecum, significant wall thickening. And then over here, all of this is right lower quadrant mesenteric lymphadenopathy. So our differential for this case was lymphoma given the aneurysmal dilatation, wall thickening without obstruction, colorectal adenocarcinoma just because it's the most likely in his demographic and he does have melena and anemia, and then just as a zebra melanoma Mets, given his history of right leg melanoma. And it came back, we leaned pretty heavily on lymphoma because of the imaging characteristics, but it came back as metastatic melanoma to the GI tract, which is not an entity that I was familiar with. So just some stuff about GI melanomas. So out of the GI tract, melanoma is the most likely to metastasize to there. GI mets are obviously less common than liver or lung or brain mets. And it comes most commonly from primary cutaneous melanomas from the head and neck, in the trunk, and the lower extremity. There's very rare instances of primary melanoma of the GI tract, but most, like the vast majority, are metastatic disease. And they prefer the small bowel due to there's an expression of a certain CCR9 receptor in small bowel, which melanoma also expresses apparently. So it metastasizes most commonly to the small bowel, and then large bowel, stomach, and very, very rarely esophagus. And we have a very poor antemortem detection rate. So 60% of postmortem autopsies are performed with small bowel mets, and we only detect 1 to 5%. So that's a pretty significant rate that we are not seeing. So this is kind of what it can look like throughout the GI tract. It has very nonspecific imaging features. In the stomach, it's most commonly like an ulcerated, fungating polypoid lesion. In the small bowel, you get more varied presentation. You can get like aneurysmal dilatation with the small bowel. You can get like a asymmetric mass or polyp. And then a lot of times it does present with like intussusception just because of the lead point. And then in the colon, it doesn't favor the rectum. It favors more like the transverse and ascending colon. And again, it can present as almost anything. It's a great mimicker of every other type of GI malignancy ever. And then rectum, more interestingly, like they do recommend rectal MRIs if you're suspecting a rectal metastatic lesion. The prognosis for metastatic melanoma is really poor. They have some new immunotherapy, which has really improved 5-year survival rate. Before it was kind of a median survival rate of 6 months, and now it is up to 5 years. And you can do metastectomies for oligometastases for melanoma, but typically they, because of our rate of detection is low, they don't typically go for a metastectomy. They just kind of treat them systemically at that point. And these are my citations.
That's a great case. Did they have it anywhere else besides the cecum, or was it just?
No, it was just the cecum.
Wow. Well, you hear a lot about anorectal melanomas. Those are rare but heard of, but metastasis to the colon itself is pretty incredible. That's a great case.
Thank you.
All right, moving on. We are going to Dr. Grace Yee, also with Emory.
Give me 1 second. I'm just having difficulties sharing my screen for some reason.
Problem.
Do you mind moving forward, and then I'll try to figure this out. It's giving me a lot of difficulty.
Yeah, I think we can do that. All right, so we'll loop back to you at the end. So next we have Dr. Matt McLean of UNC.
All righty, let me share my screen here. This one? This one? It's this one. Yeah. Wait, did you just? Okay. All right, can you see my slide here?
Yes.
No. Oh, hold on. I can figure out how to use a computer in a moment. There we go. Huh, okay, that's confusing. Your slide here. Yeah. Let's go to the next slide. Where's the next slide? There it is. All right, 20-year-old female presents at approximately 9 weeks gestation to an outside institution. She has an elevated beta HCG of 68,000. They do an ultrasound. They don't see an intrauterine pregnancy. This patient is not in any pain or any acute complaints. On the ultrasound, they did see a thick-walled cystic structure in the right adnexa. They questioned fetal pull on it. We don't actually have access to that ultrasound. They also said there was small to moderate free fluid within the pelvis. They went to surgery concerned for a ruptured ectopic pregnancy, but they just found a right corpus luteal cyst. They didn't visualize any ectopic. They looked in the abdomen as well as the pelvis. They did a DNC as well, and they had like scant endometrium, sent that. Pathology said there was no fetal tissue. A couple days later, beta HCG remained elevated. They talked with the radiology over there, and they recommended MRI abdomen pelvis without contrast. And this is what we see on the MRI, a thick-walled cystic structure along the posterior right hepatic lobe, concerning for an ectopic pregnancy, or pretty consistent with one. Ultrasound was done just to further characterize. See the ectopic pregnancy with a fetal pull and even had cardiac activity on the ultrasound. Then they went for XLAP, and they found a gestational sac adherent to hepatic 6, which was removed. And just a little bit on kind of this type of abdominal ectopic pregnancy is a very small part, about 1% of all ectopic pregnancies. There's two mechanisms that they think it occurs by. One is primary, which is the less common, which is where the fimbriae fail to capture the ovulated follicle, and then fertilization, implantation happens in the peritoneal cavity. But the more common one is thought to occur through either tubal rupture, where fertilization happens in the tube, ruptures, goes out, the uterus ruptures and it goes out, or it's aborted, like a tubal abortion, where basically it fertilized in the tube, but then it expelled out the back end and then reimplants. Typical locations are usually in the pelvis. The abdomen is more uncommon, but diagnostic laparoscopy can fail to identify it, especially if it's in the abdomen, because we're not scrutinizing the abdomen as closely, or in like a posterior, the location this was in is harder to see for them during a surgery. So MRI can be a useful tool for identifying the location. That's it.
Wow, what a great case. Was Matt, how long between... Oh, sorry, got some crosstalk.
Yeah, I can hear you.
How long was it in between the initial imaging and them doing the first laparoscopy and then the MR? Was it just so small at that time that they couldn't see it?
I think it was like between the first ultrasound and when we got the MRI. I think it was a few days, not that long. I mean, I think it was like maybe a couple days between the initial. Actually, no, I think it was like within a day of the initial imaging and going to surgery. And then it was a couple days later that they got the MRI, and then we saw that MRI maybe a day or two after that.
Wow.
But the MRI was the first imaging like of the abdomen that was done. But yeah, I guess like surgically, if it was too small to see, I'm not sure.
Regardless, great case. Very cool. All right, it looks like Dr. Yee from Emory has managed to get through, so we'll continue with her.
Thanks for waiting. So my case is a 45-year-old male with a history of melanoma. They were diagnosed in 2017. The primary was unknown, but they had no metastasis by the time I was reading his scan. There are no pertinent laboratory findings. So I guess this is going to be kind of a piggyback case off of Catherine's case. I will be going over PETs and MR images. So this is a lot less conspicuous than the prior melanoma case that we saw, but there were small bowel metastases over here as well, and mesenteric adenopathy that were FTG avid, as well as subtle melanoma metastasis in the intramuscular tissues. The reason why they actually got the MRI was because they mentioned some subtle FDG avidity in the portohepatis region that warranted further follow-up. And this actually ended up being a T1 hyperintense lesion within that region. Given the T1 hyperintensity, it was favored that this was going to be melanin from melanoma metastasis. So it's actually a tumor thrombus. And the reason why I brought up this case is because we know that the common sites of metastases include the lymph node, lungs, liver, and GI tract, but there are very few reported cases of tumor thrombus associated with melanoma. That's all I have.
Great. Yeah, another great case, companion case to melanoma. Really good to see. Something to keep in mind looking on those T1 pre-images for the characteristic T1 brightness, which is not seen in all melanoma metastases, but great to see. Okay, and I think we're on to our last person of the day, Dr. Henry Sipple of UNC.
All right. Hi, everyone. My name's Henry. I'm the other abdominal imaging fellow at UNC. I'm going to talk about a case of pylophlebitis with hepatic abscesses. So, my computer would advance. So we had a 45-year-old male present to the emergency department, acute right-sided abdominal pain, which had been increasing over the last 3 days with fevers. Do you want to get my phone? Sorry. No significant past medical history. Labs were significant for a normal white blood count, which was interesting. He had elevated AST, ALT, and ALP phos. So that's ED was thinking right lower quadrant pathology or maybe right upper quadrant pathology. So they get the classic ERCT scan, and you get your acute uncomplicated appendicitis here. You see a dilated appendix with fluid and stranding. But then we also noticed the right portal vein was thrombosed, and there was this ill-defined heterogeneity in the right lobe of the liver. So they planned for admission with an MRI. Later on, GI consult and surgery consult. However, the patient, after they got admitted, became septic and was moved to the ICU overnight, so we expedited our MRI. So starting off with the first things, we have a T2 FAT-SAT image and a DWI diffusion sequence, which confirms our diagnosis of acute uncomplicated appendicitis. We have some T2 hyperintense edema here surrounding the dilated appendix and some restricted diffusion. And then coming up to the abdomen is where we see our portal vein thrombus. So on these FAT-SAT post-contrast images and subtractions, you see that the portal vein thrombus actually has some enhancement of the portal vein, and there's an increasing amount of branching thrombus within the right portal vein. Additionally, you see another FAT-SAT post-contrast sequence and a DWI sequence. You have these small little rim-enhancing abscesses in the right lobe of the liver by that infected thrombus. And then on diffusion-weighted imaging, we see restriction of the periphery of the portal vein, as well as restriction within those abscesses. So the patient was diagnosed with acute appendicitis leading to portal thrombophlebitis, and this infection of the portal vasculature led to them developing multiple hepatic abscesses. After the MRI and all the imaging had been completed, eventually their labs came back with blood cultures for Klebsiella. Treatment for this particular disease, the mainstay is IV antibiotics, targeting gram-negative bacteria for intra-abdominal infection. Per my brief chart or literature review, anticoagulation is only considered if it's up to greater than 50% occlusive or involves the main portal vein, averaging about 3 to 6 months of therapy. For this particular patient, he kept dropping his platelets every time they tried to anticoagulate him, so he's in some complex hematology follow-up algorithm. But in summary, pilophlebitis is a septic thrombophlebitis of the portal venous system, typically arising as a complication of intra-abdominal infections or inflammatory processes. It develops when infection from intra-abdominal source spreads via the portal venous drainage, causing thrombosis and infection of the portal vein. Common causes, and ones I usually think of first, are diverticulitis, another one is pancreatitis, and then appendicitis can be also included in those causes. Not as common, but can be seen, and of note, it can be seen in non-perforated cases. Hepatic abscesses as a complication from this are somewhat common, found in about 37 to 61% of patients. I've got.
Great, thanks so much. I think we also had a case of this related to diverticulitis pretty recently. That's a interesting thing to think about. All right, anyone else on the call, any attendings have anything else to add? If not, we will wrap up.
I think appreciate everybody submitting these cases. This is a really good selection of cases. They'll all be the recordings available on the website. If you guys want to go back and review, if there's anything you guys missed, you want to take a second look at as our prior meetings. So thanks again, guys.
Yeah, thank you, everyone. We really appreciate you all participating. We will plan for the next Southeast Body Club sometime after July when we have a new batch of fellows. So again, thank you very much. Also, if any programs here or not included don't have enough fellows or have some upper level residents that are interested in body and want to participate, we want to make sure everyone can be included. But again, thank you so much, everyone, and have a great day.
Thanks, Taylor.
Thank you all.